Today we will be talking on maintenance hemodialysis as a modality of therapy for end-stage kidney failure. This topic is intended for the general physicians and the people at large who is thinking of taking up dialysis as a modality of therapy. As you all know, if the kidney fails around 90% of its function, then there is a need for extra renal support either in the form of dialysis or kidney transplants. Since kidney transplant is not available to everyone and then everyone is not suitable to undergo kidney transplantation, so dialysis remains one of the major renal replacement therapy programs. The question is, lot of patients believe that the dialysis is the end of life. This is not exactly so. Lot of people are now living with hemodialysis more than 10 to 30 years. In our center, we have 20 patients who have done hemodialysis for last 10 years and they are still living. So this is a good quality dialysis. We will be talking on the hemodialysis on 2 or 3 points. First is when to initiate a dialysis. The criteria to initiate a dialysis either in an acute kidney injury, acute kidney disease or chronic kidney disease in end-stage renal failure, there are 2 points we consider. One is serum creatinine level, which reflects the glomerular filtration rate as well as the urine volume. If both are low, urine volume is low and the creatinine is high, and obviously patient needs a dialysis. If one is, suppose a patient is having a 2.5 to 3 liters of urine and the creatinine is high, that means there is a chance of reversibility of renal failure. We should take out this patient out. Maybe he needs a dialysis for a short period. He might have a chance to renal recovery, particularly if the kidney size is large. So that requires a separate entity. When the kidneys are small in size, urine volume is not great, is say less than 1 liter or so, and creatinine is high, that patient surely needs a hemodialysis to start with. Now once you start dialysis, after a few dialysis the creatinine may come down, say 2 to 3 milligram % post dialysis, but some people often believe because the creatinine has come down we don't need dialysis. This is not correct, because the creatinine has brought down by the effect of dialysis, and therefore if the urine volume is still low, I mean less than say 1 liter or so, the patient still continues to need dialysis. If we stop dialysis, the creatinine will rise again. So there is no reason to stop dialysis. The frequency of dialysis is usually 2 to 3 per week. Most advanced countries, they do only 3 per week or even 4 per week. In our country, we say go for the step-up facilities for starting the hemodialysis. People who have got a little residual renal function with a urine volume more than say 500 ml per day, we often prescribe for 2 hemodialysis per week. But once the residual renal function falls with a decrease in urine output less than 500 ml per day, we increase the dialysis frequency to 3 per week. Having 3 per week hemodialysis with a good quality dialysis where there is no rigor and the blood pressure is well controlled, the statin is given, vaccinations particularly influenza and pneumonia vaccines are given, herpes zoster vaccine is given, and the correction of phosphates, most patients can live on dialysis for several years. And living on dialysis, say, as I said, 10 to 15 years is not a joke. I think a lot of people are doing that. And in order to achieve a high quality dialysis and high quality care, so people need few things. The blood pressure has to be adequately controlled. That maintains the good quality dialysis, adequate ultrafiltration, control of blood pressure with drugs, correction of anemia with either erythropoietin and IV iron, statins and vaccinations. All these are important things to manage the patients who are on maintenance dialysis. When the dialysis quality is poor, particularly if the water quality is poor, the patients often have rigor and they have a discomfort during dialysis and they may not survive that long. So quality improvement in dialysis is one of the fundamental things. Tubings in dialysis, has to be a single use. You can't use a single tubings in more than once, because cleaning dialyzer tubings is an extremely difficult job. Dialyzer reuse may or may not be done, but if you are using a reuse of dialyzer, you have to make sure the dialyzer reuse is done with a automated machine with a paracetic acid concentration. So all these improves the quality of life of patients on dialysis. They come, do the dialysis, and they often go home by cycling or even walking. A lot of housewives, they come doing dialysis for more than 10 years, they do their cooking and every household work, and a lot of people even come do the office work while on dialysis. So this is one of the things which has improved in India over the last few years, and we are part of them, and I believe there is no need to be afraid for the dialysis. Dialysis is not a painful procedure, and most people after few dialysis who are apprehensive before starting dialysis, after few dialysis they feel that they are doing very extremely well, they become grateful. So my message to the general people is that don't waste time to have a conservative therapy for too long. If a patient genuinely needs dialysis, you refer them to a proper place, make a AV fistula possibly at the beforehand, vaccinate and start dialysis and maintain a good quality of life. Thank you very much.